Good afternoon. Welcome back from the afternoon break. I hope you've been enjoying Metabesity Day 1 as much as I have. This is the national policy session. What should be the elements of a national policy on healthy longevity? Our expert panel will be considering questions such as those that I hope the Zoomista will post on the screen right now. But one, should the U.S. have a policy at all on healthy longevity? What should be some of the goals, elements, and objectives of such a policy? And there are some buckets proposed there: priorities and funding, regulatory and reimbursement frameworks, industry incentives, clinical practice, education and lifestyle habits, the social and economic ramifications of healthy longevity, access and equity, and there are others. Other people can organize this in different ways, and third, what are some important considerations in designing and achieving a national policy? What are some lessons from other countries? We have several folks who are experts bringing their perspectives from other countries. So I do want to start with a disclosure of my bias. I obviously do believe we should have a national policy on healthy longevity. The mission of the Kitalys Institute is to accelerate the translation of science and technology into public health in order to preempt chronic diseases and to extend healthy longevity for all. Now, just to make a distinction between healthy longevity, which is increasing lifespan with healthspan, and with aging well or successfully. The latter is, of course, absolutely critical and has been the subject of much consideration and funding for many years, but it's distinct from the question of should we promote as a country, as a society, the concept of healthy longevity. So why would we promote a policy at all? Certainly, it would help prolong or improve the quality of life and the quantity of life for each of us and our families and caregivers. There's the potential for trillions of dollars in healthcare savings in public and private healthcare costs. We had Dana Goldman and Jay Olshansky speak at an earlier Metabesity where they estimated they wrote an article in 2013 that a 2-year extension of longevity could be estimated to have cost savings or would save about $7 trillion over 50 years. There's the potential for economic growth from the expanded market for goods and services from a vigorous and active elderly. And we would promote a wisdom society that values the elderly as cultural assets rather than economic liabilities. But it's not all roses. We could face many challenges for individuals and for society and the economy, for personal and government funding of longevity, entitlement payments and so forth, and implications for the workforce, et cetera. In fact, the National Academy of Medicine earlier this year issued a global roadmap for healthy longevity under the auspices of an international commission. In August, a similar initiative was reported out of Asia in Singapore. And next month, in about a month, the NAM will host a day-long conference on this topic. One of our panelists, Professor John Beard, is a member of this August International Commission. We'll hear from him in a bit. While the roadmap hasn't been officially adopted in the US by some legislative or executive policy, it's the closest thing we have to a proposed national policy. But isn't the US a free market economy where government thumbs on the scale should be minimized? I want to first ask Tom Khalil, Chief Innovation Officer of Schmidt Futures and formerly the lead on various White House science and technology initiatives in the Clinton and Obama administrations, to introduce himself and to make his opening remarks. Tom, please.
That's a pleasure to be here. Thanks so much for the invitation. So I wanted to just make sure that we're all on the same page for what we mean when we say we have a policy or that we should desire to have a policy. I think at the core of it, it is policymakers articulating and pursuing some coherent relationship between ends and means. So that is that you have a goal that you're trying to achieve, and policymakers have identified the public and private actions that they think will have the biggest impact on helping us to achieve that goal. So the canonical questions that policymakers are interested in is, where are we today as of late 2022? Where do we want to be over the short, medium, and long term? And what are the public and private actions that are going to have the biggest impact on our ability to achieve that goal? And I think that it would make sense for the administration and the Congress to have a more coherent policy with respect to increasing health span. And I think there are at least two areas that we could talk about. One is having a set of policies that relate to geroscience, which is the idea that there are underlying biological drivers of aging, and that increased fundamental understanding of geroscience, but also the translation of geroscience into therapies could result in increased health span, which you might measure, for example, by the delaying the onset of multiple chronic diseases. And the other would just be trying to identify those actions that the government could take that would be beneficial in terms of scalable behavior change around issues like diet, exercise, and reducing the impact of tobacco and drug abuse. So the area that I've focused on more is on the first category, but I hope we have people who will address issues related to diet, exercise, tobacco, and drug abuse, because arguably that's where there's also a lot of opportunity. But I would say that right now, the Congress has inadvertently made it more difficult for the executive branch to do more in this area. And this has not been a conscious policy decision, but the outgrowth of some other decision that the Congress made. And let me provide you with a little bit of background on this. So the one important role for the federal government is supporting both fundamental and clinical research. A natural agency to tell the lead on that would be the National Institute on Aging. Congress has been generous with the budget of the National Institute on Aging, but they have earmarked 99% of the increase for Alzheimer's. So that has made it more difficult for the NIA to do more in the field of geroscience. Now, it doesn't mean there's nothing going on. The NIH has actually last year launched a trans NIH initiative in cellular senescence, but I believe that the Congress should provide the NIH and in particular the NIA with additional funds in this area, and that I think would be one aspect of a policy initiative in this area that would be designed to increase health span and, for example, delay the onset of multiple chronic diseases. Other important areas that we could get into as well, like the discovery and validation of biomarkers that could eventually be used as surrogate endpoints. But one low-hanging fruit for the Congress would be increase the NIA and NIH budget devoted to both fundamental and translational geroscience research. Over.
Thank you, Tom. I'd next like to recognize Steve Austad. He's a professor of biology at the University of Alabama at Birmingham, and also the senior scientific director of the American Federation for Aging Research. Steve?
Thank you, Thomas. Yes, I'd like to follow up on something that Tom Khalil said, which is that I very much favor a national policy on healthy longevity as well. And I say that in spite of the fact that I think the possibility of us implementing any national policy on healthy longevity is very poor. We can't agree on hardly anything. And I live in a state that has a lower life expectancy than Mexico, much of it due to conscious decisions of the government here. However, I do think that a national policy is important because already we're seeing strains, social strains between generations. Our healthcare system is groaning under the burden of the older people, older sick people we have already. And we definitely need to make life healthier for them, but also we need to figure out what to do with the people that don't manage to maintain their health when they get older. And I think that should be part of a healthy longevity policy as well. I think the document that was produced by the National Academy of Medicine, the roadmap, I think is an excellent idea. I think it lays out a lot of things. I'd love to have the Congress weigh in. I think if we do nothing more with the national policy than put healthy longevity in the forefront of national consciousness, we'll have gained something. And part of that has to do, you know, the study that Thomas mentioned about that Olshansky and Dana Goldman did to save all this money. That was only if the retirement age were raised by 3 years. And so these things, retirement policy, our fragmented healthcare system, all of these things, it would be nice if they could converge around healthy longevity. But I think if we can just make people start seriously thinking about it, we will have made a huge gain over where we are now. I think the geroscience is great, very promising. It's ironic, in a earlier session today, we talked a lot about regulation issues. And one of the threads of that thought of that panel had to do with, well, how can we incentivize people to invest more in geroscience, the private sector? Well, one way to incentivize it is to make sure they make a lot of money. But that's likely to leave out the whole segment of the population that could benefit most from any advances in either geroscience or healthy lifestyle impact. We are trying, by the way, to do something that Tom mentioned, to increase health and longevity by lifestyle changes here in Alabama, very locally. I'm in a group that's working on policies for that, and it is hard. It is hard, but it's something worth pursuing. And I hope I get some fresh ideas from this conversation today.
Thank you, Steve. I next want to call on Dave Fox. He's a partner at Hogan Lovells and formerly in the Office of Chief Counsel at the FDA. If you watched the first of the two evidence sessions earlier this afternoon, Dave led a discussion of some of the principles that may be relevant to any new regulatory pathway for healthspan products. Dave?
Okay. Thank you, Thomas. Well, as you know, I've been in and out of FDA for 28 years. So my field of vision is relatively narrow, but I'll fall back on the central principle of regulation at FDA, which is that we sat at the intersection of science, law, and policy. And right now, the science, the emerging geroscience, is wonderful and exciting. The law piece, it is what it is. It's really designed, when we come to the therapeutics area, with a different goal in mind. It is the classical sick care system, as the prior panel, I think, put it so nicely. It's a one drug, one mechanism, one disease-based system. It functions best when the intake is around products for acute conditions and people who are already in a disease state. It is not an effective pre-disease regulatory system. So as we covered in that panel, the law is a weak link in that triumvirate, and then the policy is a mixed bag. In the food space, I think there is some attention to improving lifestyle, dietary intake, sodium reduction, carbohydrate reduction. I mean, there are efforts. I'm not an expert in food policy, but I think you tend to hear articulation of policy mostly in the food space. And then, of course, we have the Tobacco Center and the wonderful work that they're doing. But in the therapeutic space, there simply is not a culture within the agency that is amenable to looking at broad classes of patients in a pre-disease state that would allow them to manage their health, their aging, their lifestyles in a way to avoid ever having to go out of balance, out of stasis. And so I think that without a national articulation of policy, we won't have the permission structure that we need to give regulators the cover and the authorization to look at their responsibilities in a different way. I think it's lacking, and I don't see it changing on its own. In fact, and not to be too much of a pessimist here, but there's a lot of discussion so far today about surrogate markers, surrogate endpoints, and biomarkers, and how that is really the key to unlock this opportunity. We have been undergoing an intense discussion, in the field about the use of surrogate markers, about the accelerated approval system. Dr. Unger from FDA talked about the accelerated approval system. There's a journal article just published showing that this is the oncology field, but 15 of the most thoroughly studied surrogate markers used in oncology yielded only one example of a correlation with overall survival. 14 of the 15 surrogates failed to show any effect, or little to weak effect correlating with overall survival. Now that's in the oncology field, but within the regulatory environment at FDA, those kinds of findings land hard, and people at the agency have a long memory. And so I would be concerned that there's going to be a high degree of skepticism for some time until we come to a new retrenchment of accelerated approval and surrogates. There'll be a lot of skepticism. So again, I think that FDA badly needs a clear vision, clear articulation around longevity, around health span, around preventive medicine, preventive health for large groups of patients. Right now, the system is really, and it's really optimized for very small disease sets, niche diseases, very high risk situations where teasing out an effect in a relatively small study is achievable. And it's oriented very much away from, it discourages going after very large patient populations. And that's a tremendous, I think, detriment. And so do we want a national policy, and do we need a national policy? Yes to both.
Thank you, Dave. I'd next like to recognize Nahid Badalia. Nahid is a senior policy advisor on global COVID-19 response at the White House. She's an infectious disease expert on leave from BU. Some might wonder what an infectious diseases expert is doing on a panel on national policy for healthy longevity, but tomorrow morning session with Bill Hazeltine will speak to the fact that COVID has blurred the lines between acute and chronic diseases, and in fact has given birth to a brand new chronic disease, long COVID. So Nahid, would you please introduce yourself and your opening comments, please?
I think you set that up rightly. And I wanted to step back a little bit. Nobody had heard of infectious diseases physicians actually until COVID started. Now we're in every household. So we'll take the opportunity to share the rest of the aperture that covers our work. And what I wanted to do is actually widen the aperture a bit more on this conversation that Tom framed at the very beginning. What are the components? If there is to be a national policy on longevity, what should be the components be? And generally, as an outsider in the field of longevity, when I think about it, to the general public, longevity generally refers to incremental benefits of interventions, reductions in harmful, harmful risks that could decrease your lifespan, or, additions of beneficial things that can increase your lifespan. We always think of it as something that's intrinsic. I want to step back and say pandemics, my field of infectious disease and epidemics, and COVID-19 has very clearly showed this, actually pose an equal threat to longevity, but at a population level that is so wide, it represents a sudden disruption that actually goes across all the different things that are covered in the NAM report that you referenced. They touch everything from social cohesion to financial stability to healthcare resilience to everything else in terms of, you know, depression and long-term sort of survival from other chronic diseases that are posed. And to make my case, I wanted to point out to the fact that when we think about COVID-19, and unfortunately, I thought I was going to be able to share my slides, but let me describe to you what I'm looking at. We've had a pandemic over the last 2 years that, from a WHO report this spring, suggests that we've lost about 13 to 16 million people in excess mortality compared to what we thought we were going to lose. And that is a broad amount of people we have lost across the swath of the entire global population. But when you look at the actual decrease in longevity, and I think you've heard these numbers, this pandemic has decreased the lifespan of Americans, you know, more than we've seen since World War II. And that decrease is across every single demographic and actually acutely felt differently across different racial groups, reflecting social determinants of health and other aspects, right? And so the idea that pandemics represent a sudden shock to the system then says to me that part of how we think about a national policy for longevity should be how the system can protect vulnerable people who are at high risk, as well as the general population from a sudden shock. So in pandemics, and just stepping back to my own experiences, I've, you know, aside from the response during COVID-19, both now at the policy level right now and being a physician at the front line, but also having worked in the past in communities affected by everything from Ebola to Crimean Congo hemorrhagic fever, those sudden disruptions have not only the direct health impacts, but they've delayed population level health interventions. And hence you've seen across the world currently a drop in everything from childhood, you know, vaccinations to ability to screen for other chronic diseases, to drop in tuberculosis and HIV screening, to treatments. All of those are affecting longevity from, you know, from other diseases that we've been able to address. It also delays access to care in sort of the heat of the moment when you have high amounts of healthcare utilization. A sudden shock like a pandemic, and natural disasters are similar to this as well. A sudden pandemic represents the ability to potentially now take away immediate access to care from all causes, not just the disease that we're looking at, a diversion or loss of human and physical resources. Essential medications is a perfect example of this. You know, we've seen some medications used in chronic diseases being diverted, for example, for use. Hydroxychloroquine was a good example of this. The impact, the secondary impact that one big health crisis has on all other things that are chronic diseases, as well as elements that determine a person's length of time on this earth. Then there's disruptions in social services, financial instability. There was an IMF study that about 3 or 4 years ago that showed that in the aftermath of every epidemic, you see the Gini coefficient increase. That's the marker of social, you know, inequity, economic inequity. And we're already seeing that here in terms of coming out of this pandemic, the economic impact this will have felt most by those who have the intersection of being both of higher age and potentially at a lower socioeconomic status. And then the impact on mental health. And so when you think about designing, in my mind, when you think about designing a national policy, you need to pay attention to the fact, for example, that the chances of dying of COVID are 340 times higher for someone who's 85 and older compared to somebody who is 18 to 29. And so we know that this is coming. How do we map vulnerabilities for high-risk patients, particularly as we enter an age of epidemics? You know, COVID is not a one-off. We live now in a time where we will see continuous epidemics from the impact that we've had on the world around us. And hence, in my mind, a huge part of what we need to do is look at the implementation research that goes into mapping out both good data collection on those patients who are going to be high risk, flexibility in healthcare response, increase in healthcare resilience during a surge, and then equity and access to medical interventions, as well as care when something like this happens. So a broader aperture, but I'll put that out.
Thank you, Naid. I'd like to next recognize Evelyn Bischoff. Evelyn is zooming in from Israel. She is a longevity physician for Human Longevity, a San Diego-based premium membership based healthy longevity practice or service. Maybe she can explain it better than I did, as well as experienced in international medical practice, including in China. Evelyn, are you on? Can you get online?
Yes, please? I'm on. Thank you so much for having me. And yeah, great.
Thank you for staying up late to join us. I see that.
So it's a pleasure. It's a pleasure. Regards from Israel. And thank you for having me on the panel. Well, yes, I am coming from purely clinical medicine. So my primary day-to-day work includes, besides of now, really being in the ICU and internal medicine / oncology ward. So coming from really multi-morbid, complex patient settings, very often also end of life or very acute type of disease settings, I see how well, right, the sick care has developed the lifespan towards extension. And I think we have to keep that in mind talking about longevity. And so the other foot of mine is in human longevity, but also I have my own longevity patients in China and globally, where we are focusing primarily on the health span. And there is a debate about the definitions, and I guess nobody really wants to claim it. However, it's important to definitely have this understanding that longevity or healthy longevity medicine is not about extension of lifespan, primarily at least, but extension of the health span. And if that could be one of the consensuses in the policies now being this national or in general global health policy, that would definitely make the life of the physicians much easier. Since then, it would be also much more approachable for patients to understand what the doctor is then actually doing. I still see that there is a lack of understanding even in patients, and it's very hard for them to distinguish between a doctor who is leading them as a longevity patient or whatever definition the doctors choose for those type of patients, and a patient as a patient in a hospital, in a sick care. And very often it comes together, it confluences. I think the role of a longevity physician is a very important one. And that brings me to another point that I hope we will see also in policy making, and more physicians also joining the field of public health, is number one, education. So implementing healthy longevity already into the curricula of medical schools, or at least some very good continuous medical educational programs for residents, fellows, and senior physicians. And at the same time, also implementation of the role of longevity physician as ultimately those people who will be responsible for applying the solutions, interventions, diagnostics that we might have. And a step before that, also to execute the randomized controlled trials that will ultimately validate biomarkers, and then hopefully based on that also the interventions. So so it would be very nice to have the field evolving, and as we are evolving, to have the policymakers, authorities, and of course related bodies and stakeholders to consider those specific aspects.
Thank you, Evelyn. I next want to call on Tina Woods. Tina's zooming in from the UK. She's the founder and CEO of Collider Health, and she played a major role in the UK all-party parliamentary group on longevity that led the UK to adopt a national goal to achieve a 5-year extension in health span with equitable access by the year 2035. Tina?
Yes, thank you, Thomas, and thank you very much for inviting me. So, yeah, so really, really fascinating to hear the speakers so far. So I'm going to touch upon some of the points in turn in the context of what I've been doing and and going to be doing ahead. So yes, you mentioned the APPG for longevity. And actually that goal that you specified, 5 extra years of healthy life expectancy while minimizing health inequalities, that was actually a goal that was set as part of the industrial strategy laid out in 2017. So it's been around for a while, but what was really important about that, it was obviously a government commitment to achieving this goal that also framed the Grand Challenge program that has been underway since then. And we speak about the National Academy of Medicine Global Healthy Longevity Roadmap program. Well, we've had a similar initiative that's sort of been happening since 2017, which is part of the industrial strategy on one of the grand challenges called the Aging Society. And I worked and continue to work on the healthy aging element of that. And the 3 other challenges, which interconnect, of course, were to do with AI and data, clean energy, and mobility. So there has been this government commitment for quite some time, and actually it's in the current government's manifesto commitment. So that has been really, really helpful in terms of taking a mission-based approach to engage with policymakers, but also, as we know, all the other stakeholders that you really need to bring to the table when you're talking about really what effect is a huge system change exercise. Taking what has been described, I know, by many people here now, is we effectively have a sick care model, and yet you look at the UK and the USA, two of the richest countries in the world, who spend a huge amount, much higher than many other countries as a proportion of their GDP, on sick care. And yet here we are post-COVID, we've seen a decrease in life expectancy, a stalling in healthy life expectancy. We have a widening gap in the UK, certainly, between the richest and poorest citizens, at almost a 20-year difference in healthy life expectancy, which is actually at risk of becoming worse because of the post-COVID challenges that we face. So, we have to ask ourselves the question, what are we doing? So this is obviously what we've been really trying to grapple with in all the things that we've been doing, initiated by the APPG for longevity. And we have 2 core work streams that have been very, very busy since COVID. And ironically, we presented our strategy a month before COVID, and I had just come back from Singapore, inputting into the Healthy Longevity Roadmap, the National Academy of Medicine. And suddenly COVID hit, and we realized that all of the recommendations to achieve this goal of healthy life expectancy, minimizing health inequalities, they're just as important, in fact, even more important as we were seeing the data come out. So so I agree. So just touching upon, before I go into those core work streams, I agree, for example, with the points that Tom made very, very succinctly about, there are 2 streams that we can take with this. There's obviously the geoscience route, and actually there's some pretty heavy-duty economic arguments. I mean, if you look at David Sinclair and Andrew Scott's article that appeared in Nature, for every extra year of healthy life expectancy, you are achieving about $38 trillion, dollars economically, and we've got some figures for the UK as well. And I also think I absolutely agree with Tom about scalable behavior change as a really important plank. So that's really what has been the focus of a lot of our work. So public sector investment, absolutely key. Currently, we've got a new government in the UK. They are very, very hell-bent at growth at all costs. Now, we are coming in saying, listen, you cannot have economic growth ignoring health. It is just not possible. We've got so much economic evidence. So, you really have to not forget that. And so that's going to be very much the basis of our work ahead, speaking to government, policymakers, and the investment community. So really, really important. I completely agree about the need to move upstream, we know that Alzheimer's is the pinnacle of the chronic diseases of aging. We need to move upstream to the more prevention angle across the life course. We need to focus on health span. We need to bump up our investment in research on aging biomarkers, as proxies, etc. So all agree with that. And just as a segue in terms of, I guess, my current activities, I'm very, very involved in running a group called Business for Health, which is essentially trying to take what's been happening in climate over the past 10 years, but bringing health into ESG. So really incentivizing investment by the trillions that are sitting in pension funds, to invest in preventative health and care, and to bring, returns on social impact, not just on academic. Well, we're saying that it all goes together. You can't have health without wealth. You can actually be very successful, develop, get your commercial returns by investing in health, because you actually need to. So that's a very, very big part of what we're doing in our sites, is really looking at, for example, the key areas. We talk about impact, we talked about tobacco, we've talked about lifestyle, fitness. Well, one of the biggest areas that is on our map is looking at the food system shaping. We know ultra high processed food, we're eating way too much junk food. The food industry has a lot to be, answerable to that one. So we're looking at how we can incentivize, for example, the food industry, right from sort of, the farm to the table, to invest in, what will contribute to positive health rather than increasing harm. So this is a really big area that we're focused on. And finally, I will just finish on my latest sort of set of activities, which is all around creating what effectively is a healthy longevity innovation mission. So it's a moonshot. We're working with the National Innovation Centre for Aging in the UK. They're based up in Newcastle. They've already been developing for export, templates for longevity cities. They've got an Internet of Caring Things pilot. And really what we're doing there, and I think this is really important because it speaks to the psychology of aging, the behavioral aspects of all of this. We need to see, all the animal studies underway. In the end, they have to translate into, to success in human beings. We are not nematode worms. We are, you look at the increasing evidence on, optimism and sense of purpose and being open to new things, all the research that's showing how important that impacts on the physiology of the aging process and epigenetically. So that is a huge open space that we're really looking at closely. And it's so fundamental to addressing, all the behavioral sides, the psychology, and, really to get that scalable behavior change that Tom mentioned. Absolutely fundamental. And it completely connects with really understanding the wider determinants of health, which unfortunately just aren't being given enough attention by policymakers. Well, they're starting to, but it really is so fundamentally important. So I will hopefully be allowed to send a link to an event that we're running during Longevity Week next month, which is essentially laying out a blueprint for effectively this moonshot to really invest for health and prevention, because it's so critical at this juncture now post-COVID. So I'll stop there, but enormous opportunities and challenges ahead to collaborate on a global scale, to really think differently in this space and get the money to where it needs to go.
Thank you for that, Tina. And I don't know whether it's posting in the chat, or we can certainly post in the resource materials for the session so that conference goers can check that out. I'd like to next call on Adrienne Mendenhall. She is the Global Business Development Lead at Access Health International. She's based now back in the US, but after a decade of living in Singapore. So I think she'll have some very interesting perspectives for us. Adrienne, can you get online? And I apologize, I think you had some slides too. We seem to not be flashing them, but hopefully you can describe your comments.
Yes, hopefully after 10 years in Singapore, I can describe their work on aging well. And Tina, I was at the same workshop, February 2020, in fact, I think someone made a remark of, this showcases how much trust we have in the Singapore healthcare system, is we're all sitting in an auditorium together as we know this pandemic is on the horizon. So, I want to make a few points. And the first is, one thing that we talk about a lot is what is unique from an international perspective is Singapore's whole of government approach to aging. So very similar to what Tina just described that's happening in the UK right now as well, is that Singapore they really look at how they can implement a national aging strategy across all of the ministries. And this is really grounded with the Ministerial Committee on Aging. So the Ministerial Committee on Aging was launched in 2007, but its history goes all the way back to 1989, where there was an advisory committee for aged care. And it's gone through different iterations over the years. But in essence, what it is it is a committee with representatives and ministers from approximately 10 to 12 ministries, and along with charity organizations, civil society, some of the workers' unions, et cetera. So they take a multi-sectoral approach to look at what the strategy should be for the country. And we think that this can be an inspiration, not only to other countries, but in the US specifically, also at the state level, county, and municipality level as well, to say, how can we set out strategies around healthy longevity and look at all of the levers that we have across government and through our partnerships to enact these policies and to enact these strategies. So The Ministerial Committee on Aging in 2015 launched an action plan for successful aging. It has over 70 initiatives across 12 different focus areas. This includes housing, transportation, urban development, learning, and also research as well. I mean, there's a number of areas. But what this does is a few things. One, not only can you set a goal on, for example, active aging, and then say, how do I work with the transportation system? How do I work to make sure that we have healthy, safe ways for people to be active in their communities? How do I invest in communities so that it's easy for people to be active? But what it's also been able to do is Singapore, by investing so significantly into aging, is this has become part of public discourse. When you open the Straits Times every day, you're going to read about aging. When students are in university or their technical colleges, they're going to be talking about aging. When the Singapore government, essentially there was, I want to say it was, don't quote me on the exact year, but in 2013, 14, 15, all of a sudden, when we saw research funding flooding into the field of aging, is people who had worked in other disciplines in the past, and I'm talking outside of healthcare, but business schools, architecture, design, all of a sudden, when the funding was available for aging, they started to focus on aging. So not only were researchers focused on aging, and then you're steering part of the innovation community towards aging, but now their students are talking about aging as well, which meant that I would be interviewing a potential intern in the business school, and she said, I had been focusing on aging in all of my classes. And so now you have a young generation that's talking about aging. It's no longer the problem of just healthcare and social services. It's no longer the problem of just older people, but now you have 20-year-olds saying that they are passionate about aging. And so another thing that, I don't know if this was meant as part of this strategy, but one thing that I see quite a bit in Singapore versus maybe some other countries where, we're talking about aging is also ageism. And I think this is a big part when we're going to talk about a national strategy or a national policy around healthy longevity is how does that also impact ageism? And how that has to do, how we saw that mostly come out through discourse during the pandemic. Going back to, early 2020 is one thing that I would hear quite a bit from a range of individuals is when we knew very little about this virus of saying, you know what, it only affects people who are older. You don't have to worry. And I wonder at which age do I become an only? When do I become willing, at what point can I be sacrificed so someone can get their hair done, their nails done? At what point does that happen? And is it because we're not talking about aging, we're not investing in aging? Whereas in Singapore, what I do see quite a bit is through these strategies of saying, for instance, one of the initiatives is the Skills Future program. Skills Future has government subsidies that each citizen gets that they can bring to institutions of higher learning, any certificate level courses, et cetera, so that they are continuing their learning. The reason for the Skills Future program is multifold. Part of it is so that someone can make that mid-career change, make that shift into a different area, but also it's so that older people can continually have access to the education system and they're continuing to learn. It's a way to fight dementia. But it's also implicitly making the argument of we're going to invest in older people. We don't just invest in younger people because older people are also a resource. And if we can keep people active and engaged in their communities, they can continue to be a resource. And just one other thing that I wanted to add as well is that around, I don't know exactly how many years ago, within the last decade, there was a shift as well from talking about a silver tsunami to talk about older people as a resource and being able to say, we should be making these investments. And for the larger community it shifted how people looked at, I would say it shifted how younger people looked at older people as well, is when the government stopped talking about silver tsunami as all of these costs are coming at us and we have to find a way to mitigate them. Instead to say, let's ensure that we have a society that is equitable for everyone across all ages, where people are included in their communities, where they feel that social cohesion and that social inclusion, because we know that's also one of the biggest risk factors for chronic diseases and aging, and those getting worse as well. And then also to make sure that at the individual level, people have opportunities to be engaged in the communities where they live and to stay active as well. So those are my initial comments, and I look forward to the panel discussion.
Thank you, Adrienne. I'd next like to recognize Professor John Beard. He is zooming in from Geneva, I believe, tonight. He's the ARC Center of Excellence in Population Aging Research. He's a professor there at the University of New South Wales. As I mentioned, he is a member of the International Commission on the National Academy of Medicine Global Roadmap for Healthy Longevity. John, can you patch in, please?
Yeah. Thanks, Thomas. And actually, before my current position, I used to be the Director of Aging with the World Health Organization. So like a couple of the other speakers, I've had the privilege of being able to see how countries around the world have tried to tackle this same issue. So do we need a national policy on healthy longevity? Of course we do. And why? Because the system's broken. As I think David said very eloquently, it's well designed to deliver one drug for one disease. It's very much designed for acute conditions or injury rather than the chronic conditions, which are the overwhelming burden of disease these days. And when people have chronic conditions, they more often than not have more than one of them. So the majority of people over the age of 65 have multimorbidities. So we need systems which are designed for the burden of disease that the population faces. And we know that those systems, the best way of delivering the care they need is to deliver integrated care. That's focused around the holistic needs of the individual, and yet that's just not the way our systems are designed. And more recently, as people have touched on, we're starting to find out that there's actually really strong scientific base to explain all of this with the emergence of geroscience. That we can see that diseases aren't all occurring in isolation. They're driven by these chronic, these life course associated changes at a much lower level, which become expressed in different ways. And if you look at the US specifically, the US has, if not the most, certainly one of the most expensive systems in the world. We don't actually get a good result for that. The US does not have a high life expectancy by international comparisons, and the life expectancy is incredibly unevenly spread. So there are great inequities. Some people enjoy already healthy longevity, so we know it can be achieved, but the vast majority of the population don't. So what we need to do is to shift our focus to ensure that everybody can enjoy that same experience. So what can we do? What the Commission said was, first of all, we need to have a much greater focus. Well, healthy longevity is a life course issue. It's not something that you wait till old age to try and address. So we need to be thinking about what can take place across the life course. There needs to be a much, much greater focus and investment in terms of public health, disease prevention. We need to be looking at the social and the environmental determinants of health. We need to be thinking about how we can influence behaviors in a scalable way, as people have focused on. We need to reframe our health system so they deliver integrated care. We also need to think about long-term care for people who have had significant losses of capacity, and that needs to be also integrated with health systems. And we need to not just think of long-term care as about institutional care, but about all the different ways we can provide care and support to people who need it. And underpinning all of that, we need to reframe our research agenda and start to think beyond the disease-based paradigm that's got us to where we've got to quite well, but it's now outdated, and we need to be thinking about how we can make the investments to look at those underlying physiologic changes which are driving all these things which we're seeing. And I also think it's really important, and I'm really glad that Adrienne raised this. We need to address ageism because it's pervasive across society is this idea that older people older age is a negative thing, and that older people are frail, a burden. There's a them and an us. There's not. We just live all together in one continuum of a life course. Some people have different needs, and we need to be structuring our system so that it meets those needs wherever they occur across the life course. I'll leave it at that because I think I'm looking forward to the discussion.
Well, what an embarrassment of riches. As we've said about other sessions as well, we could have a whole day or days of symposia in discussing these issues. But maybe I could start with a pretty general question throughout the entire panel. You've been listening to each other. One of the things we like to do at Metabesity is to put together, our inspiration is to hold a dinner salon as opposed to a series of folks at lectures at a podium. Are there points that you've picked up from other speakers that struck you, or connections, or things you object to or disagree with, just to get things started? And this is for anybody. So maybe I see Nahid holding up her hand, please.
Yeah, I just cannot stress enough how much I agree with what Adrienne said about just the approach to this pandemic, right? When we thought about the idea of this just is something that affects one segment of the population, hence, this is their problem and we're not connected. And the reason this appeals to me is that in infectious diseases, whether it is inequity at the level of what age group you're leaving out in the cold versus what marginalized group or minoritized group you're leaving out in the cold, it doesn't matter, because if the levee breaks and there's flooding in the community, if there's infectious diseases, it's communicable to everybody. And so that impact is so shared, you can't just focus on one part of the population. But the other thing that I think I mentioned this when we had an earlier conversation, which is we talk so much about changing individual behavior. An interesting part about this pandemic for me was, how do you convince people to change their behavior for other people's health? I mean, yes, this comes up with like smoking and other things as well, but how do you convince people that their actions, even if they themselves may not feel the same level of health impact, that it's what could be sniffles to you may actually carry a larger potential health impact for others. And as a community, we're sort of all involved, because this was one of the hardest things for me to communicate as a public health person throughout this pandemic, is sort of then pointing the line back to saying, well, then shared healthcare resources are overwhelmed, which affects everybody, right? So you may think that this COVID infection for you is not that severe, but the impact on the healthcare system then is affecting everybody as well. So it just, it resonated really a lot.
Any other hands up? I see Tina and Adrienne. Tina first, please.
Yeah, well, just to echo the point about ageism, because I do think that's one of the biggest barriers to progress, if not the biggest one. So could completely echo that, and also very much agree with Adrienne's assessment about what is working really well in Singapore. I mean, clearly there has been a top level, government commitment to this. And it has pervaded all of society. And I think we need to do the same. There's medical school training and curriculum, training up doctors to really understand this. We're starting to see concepts in the UK press, for example, hitting the mainstream around biological age. So we do need to use all the levers at our disposal to get the message out that aging is malleable, you can do something about it, et cetera, et cetera. The other thing I think, which is a really interesting one, is this whole idea of sort of this collective shared endeavor, that we are all in it together, which I think is something that from a data perspective, there's a very interesting group in the UK called Our Future Health, which is just embarking on probably the biggest study on understanding health as opposed to sickness. So they're taking blood samples they're recruiting 5 million volunteers. So this is a massive research program, which is engaging citizens, and they're trying to find citizens from all walks of life, all ethnic groups, etc., so that we really get a diverse sort of data set to really understand what is putting people at risk of ill health. And I think if we can take some of these ideas, and these are some of the things that we're tossing around with the innovation mission, to really incentivize public involvement involvement in research so that the benefits will benefit everybody and will also drive commercial returns for enterprise. So there's a win-win. So this is where the H into ESG investment comes in, but it's also, how do we manage that ecosystem that we can incentivize data sharing? So I think these are some of the really interesting ideas that speak to this need to, as this is a collective endeavor, that we all have something to gain by increasing health span, but also about making sure it's accessible and to democratize the benefits of that. It's much better to have a fair distribution of all the benefits of the research. And this is something that, is at the heart, certainly what the UK activities are all very focused on. So agree with that.
Adrian, Tom, Steve, John, Evelyn, we have, by the way, it doesn't have to be like by hand. If there's a way in this digital format to have a fur-flying discussion, interactive discussion, I'm happy to get out of the way, but at least let's start with this. Adrian, you're next up, please.
Yes, I was just going to add as well, is when we look at, when you were asking earlier about, how do we get people to change their behavior in mass in order to protect people who are maybe more vulnerable. And I think shifting the conversation from COVID to also saying, early on, there may have been factions who are comparing COVID to the flu. We know that COVID is not like the flu, but we now have a really bad flu season just ahead of us. So how can we take those lessons on what worked and didn't work in the US and start to apply it to other disease outbreaks as well, especially when we look at, from an equity perspective, on what really worked when we started having community-based vaccinations and going into communities and conducting both education, working with different groups to get those messages out about the safety of vaccines, but also how do we get messages out to ensure that people are trying to protect their loved ones who are maybe who are going to be vulnerable to both a potential third wave of COVID, but also the flu season this year as well. The other thing that I wanted to add is, as we bring the conversation to healthy longevity across the lifespan, not just at a certain age, one thing we always say is aging is a process, not an identity. It doesn't start at a certain year, but it of course is, happening throughout our life. Is Singapore has also I want to say within the last couple of years, launched a ministerial committee on health. So now they've taken the lessons of the Ministerial Committee on Aging and said, how do we start to impact and promote health across the lifespan? And so the Committee on Aging was going back a decade, and finally we're just saying, okay, let's also look at health for everyone and look at how we can promote that, again, using all the levers of government. And sometimes these are even small things where Singapore has this card you can tap at busy intersections to get extra time to cross the road. And knowing that if people don't have that extra time, they won't cross the road. So for instance, I lived on an 8-lane street, and my father-in-law thought this was the most brilliant thing he'd ever seen before because it takes him a long time to cross the street. And if he can't do that, he can't get to that part of the neighborhood. And all the way through to, of course, just making neighborhoods more accessible, making activity, making the right choice, the easy choice. So for instance, the bus system, they make sure that you have to walk to the bus. It's not about making sure that the bus stop is as close as possible to your house. It's everyone should be within a 10-minute walk of a bus stop, but we're not going to necessarily ensure that you have a bus within 2 minutes because we want you to walk to the bus despite the heat. And that's part of, it's just another example of where they're baking in health promotion to policies in the other ministries as well.
Terrific. Tom, then Steve, John, and Evelyn. But Tom, go ahead, please.
Yeah, I was interested in David's observation about current FDA policy being focused on the specific relationship between one drug and one indication, and was interested in whether he'd come across ideas for what a broader paradigm would look like. One idea that comes to mind is the work that Nir Barzilai and his collaborators have been doing around the proposed metformin trial, where they would use a composite endpoint on delay of multiple chronic diseases. but I'm wondering whether there are ideas either on the FDA side, and if you feel comfortable talking about it, the CMS side, that would incentivize researchers and the private sector to move away from necessarily the sort of one drug and one indication paradigm.
Yeah, thanks, Tom. I mean, so there are multi-drug approaches to treatment, and in fact, across almost every major disease set now, we've undergone quite a revolution towards synergistic effects, cocktails, complementary therapies. So I not to, that one drug paradigm is in some ways an oversimplification, but it's always targeted at a disease state that's already emerged, and a kind of targeted mechanism of action based on the patient already being out of stasis, already being in a disease state. And so most of the paradigms around managing individuals prior to a disease state in our U.S. system, it's a self-help system. So in fact, one of the major pieces of legislation affecting dietary supplements in this country in 1994 was basically a proclamation that if you were interested in trying to manage your health yourself through any kind of nutritional supplementation, you were on your own and you needed to do your own research, because Congress took away any incentive, any requirement to provide evidence to support your claims. And so we ended up with mush. For those people who, for people who do want to think about it and do want to try to maintain, health over the course of their lives, in the current system without a policy, we actually have a negative policy, which is you're really on your own. So I think the key here is a system that rewards evidence, but the current system is not calibrated at all to the type of evidence or endpoints that we're talking about. And as I said before, just to reinforce it, as the time goes by and we watch the new drugs and new biologics, new therapeutics that are approved each year, it's narrower and narrower, higher risk, more niche diseases, all of which are actually, terribly vital, very expensive in the marketplace, but pretty much the predominant place where investment is going.
Thank you for that, Dave. Steve, I don't want to deflect you from the point you want to make, so please make it. But throughout the day, we had Ken Dykewald make the point that a lot of the funding has gone into Alzheimer's as opposed to geroscience research. Tom, just at the top of this session, was talking about the mismatches, if you will, in funding. So because of your unique perspective in geroscience and with AFAR, I'd be very interested to hear whether you had any further views about the kind of research priorities and funding levels. I recall Matt Kaberlein at one point noted that cancer research gets $200 billion a year in the U.S. and what is aging research, maybe in the single digits somewhere. Steve,
yeah, well, I do have actually a lot to say. Of course, I am in favor of a massive increase in funding for the NIA. But I do think the field has benefited somewhat from the emphasis on Alzheimer's disease because it has led to a small increase in the non-Alzheimer's. The other thing is that some geroscientists have gone into Alzheimer's disease, but with a different focus. They've gone in with a geroscience focus. And I believe that when we really can manage Alzheimer's disease, it's going to come from aging research. It's not going to come from people studying Alzheimer's disease specifically. It's going to be, and a lot of the geroscientists that are now working in Alzheimer's are actually taking the lessons from what they learned before they went into that disease and are taking that with them. So I think it would be nice if half of that money had gone into basic geroscience instead of the Alzheimer's disease, but I don't think it's quite as bad. And then if with the infusion of private capital into geroscience, the field is richer now than it's ever been. And I think that there'll be dividends from that already. And as someone who went with Nir Barzilai to the FDA to talk about the metformin trial, I came out of that thinking this was not as bad as I thought. In 5 minutes, they said, okay, the basic idea we're for, now let's explore the experimental design, which, considering that we had spent weeks and weeks and weeks trying to figure out how to bring them on board, and the fact that they said, okay, now prove it. Now tell us about your experiment, I thought was a great advance. The point I really wanted to make, though, is about education. I think I'm the only one on this call that routinely teaches undergraduates, but I teach a course called Aging Cells to Society. So I'm talking to 20-year-olds about what it's like to age, what can be done about it, are we taking care of it in the right way? And they love it. These courses grow like crazy. So I think in terms of getting rid of ageism, one of the ways that we need to do that is to get it into the schools. And I think college is great, but it would be great to get it earlier. And I think that young people would be receptive. They'd look at the world in a new way. I have students go out and they actually time how long the walk signs last going across the street. And then they time older people walking, and I show them the disconnect between those two things. So I think one of the things that a national policy could do, because we're not centralized like Singapore, unfortunately, we can't have these top-down decisions. But if we get something if it soaks into everybody, then even on a local level, we might be able to do some things we couldn't otherwise.
Sean, do you have something to...
Thomas, I wanted to make it clear that I'm all in favor of an increase for Alzheimer's. It's a terrible disease, and I'm all in favor of increasing R&D to try to address it. My only point was that by earmarking virtually all of the increase in the NIA budget, I think the Congress inadvertently made it more difficult for the NIA to pursue a broader initiative in geroscience, which I think would have enormous dividends. And I think that this is largely a result of Congress not being as aware as would be desirable of some of the early exciting results that we're seeing, both from academic research, but from the growing private sector activity. And a lot of the companies that have raised funding are now going on a hiring spree and hiring all the professors. So I think we're going to need to invest in graduate and postdoc level workforce, so that we continue to have an academic workforce to help prepare the next generation of people doing geroscience research on both the fundamental and translational side.
Well, yeah, if I could just respond to that, because I absolutely agree with you, Tom. And one of the things that we found, so we've been doing some lobbying with congressional staffers all over across the spectrum. And once you explain to them, we haven't found anybody yet who thought that keeping older people healthy longer is a bad idea. So once you present to them the geroscience idea, it's not hard to get politicians to agree with that.
Can I maybe turn to John? I think you had a hand up for a while.
Yeah, a few points. It's interesting, Steve was talking about cells to society, and I think at both of those levels, what we need to do is think very broadly. At a social level, if you're going to set national policy, it needs to be a whole of government effort. And it's not just actually at a national level that you can do that. There are some terrific initiatives which are taking place around the world at a city level, at a municipal level, where there's a global network of age-friendly cities which tackle a lot of the things which people are talking about. And it's funny that at that municipal level, it's often it seems to be easier for them to bring together all the different departments to try and work together to address the things they're trying to do. And then if you look at a cellular level, it's the same thing. Now, I'm a big supporter of geroscience, but I think we have to be honest and say that the evidence is really pretty thin at the moment. Where it's enticing, but it's not strong. And I think rather than, there needs to be a bigger investment in the area, but I think the biggest thing that needs to happen there is to break down the barriers that actually force funding to go to more narrow endeavors. So it's not so much as let's create a funding mechanism for geroscience, it's let's break down the current funding mechanism so that they can incorporate that way of thinking. And then the final point that I wanted to make is an economic one, because when we talk about doing all this sort of stuff, people say, well, you can't afford it. And in fact, you can. If we compare, for example, Germany, which now has a universal health system and a universal long-term care system, those things have not impacted in a negative way on their gross domestic product. And in fact, Germany's outstripped the US over the last 15 years, I think, at a individual level for GDP. And similarly, if we think about ageism, one of the things that I've had to work with a lot of private sector, major corporations and small companies over the past 10, 15 years. And one of the things that ageism does is it narrows people's understanding of the opportunity. It narrows the private sector's understanding of the market. And they miss the opportunities that are right there in front of them because they have these blinkers on and think about aging and longevity in a set way. And so I think, and this came through pretty strongly in the roadmap from the Commission, was that most of the investments which we're calling for will actually pay for themselves and very quickly. So we shouldn't shy away from making some big investments in this area.
John, just to comment on your we can afford it point. I've heard it, I think it was Nubar Fayan of Flagship Pioneering at the Milken Institute in June. I heard him make the comment that if we as a society sustain the kinds of losses from various sources, including chronic illnesses, and you compare that to what we would do in national defense, if we lost 3,000 people, not to compare deaths or anything, but if you look at the kind of response that we were able to mount, and you look at the lesson from COVID, the response that the globe mounted and the costs that we were willing to incur in order to save those lives, I think it reprioritizes, or at least it opens up the walls and helps us to reimagine a bit what is possible and what is not possible. I think, Evelyn, you've had your hand up for quite a while. I saw that you had a comment in the chat about possibly making available talking about education. We can talk about college students and even earlier, but I know that Evelyn has been particularly active in helping practicing doctors to learn about longevity. Evelyn, I don't know if that was the point you were going to make, but please.
Right. No, thank you. And not the only point, right? So I think I mentioned in the beginning that education is, as mentioned by several panelists here, a big and important point for me. Actually, with help of Tina, we were able to implement the course of longevity medicine for physicians on the NHS platform, which was a major revolutionary step, I would say. And it spread over to other countries. But talking about national policy or policies in general, and knowing the great examples of such as in Singapore and also in the UK, Switzerland is doing also very well in terms of implementing very good regulations nationwide. Those are obviously smaller countries. I would like to bring an example from China, which is very specific in terms of regional policies and national ones, but healthy longevity has been a priority since 2020, before COVID hit, right? It was on the panel of the 5 years project, and it was one of the top priorities. What has happened so far is the ministers have been working together also in implementing different solutions, not only for aging or aged people. That has been established in China for a while, as we know. They do take care a lot of those people who are 75 plus. In terms of lifestyle, exercises, facilitating everything in the cities and outside for those people to stay active, to have the ability to access institutions, sports, nutrition, etc. But also really targeting the new generation with all the types of wearables, monitors, and etc. That is very let's say cheap. Pretty much everybody can afford it. It goes down to very, very low prices of very, very good technologies that are available for everybody. And statistics show that China has the highest maturity for AI in society. So pretty much everybody's using AI for everything. And this led also to the point that people are willingly collecting and sharing healthcare data where it makes sense. And what the government has now achieved, and I don't know if we have time even to discuss that on a larger level, they have involved insurance companies, public insurance companies that are now implementing specific programs or additions to insurance programs that are specifically implementing healthy longevity, meaning the patients, the insured people, the healthy ones, right? The young people receive wearables, they receive access to platforms where they can collect their biomarkers that are not graspable by any EMR system of the hospitals, and so on. So we see that happening, and that is quite promising, and I hope we will see that also in other countries. Right.
Thank you, Tina, and then Adrienne.
Thank you. Yes. So just to very quickly pick up on Eveline's point about the need to train our new doctors and to engage a much wider sort of debate on this. With many of the doctors that I speak with, they are absolutely desperate to get more training and focus on the whole kind of preventative health agenda, healthy longevity. So I think they're absolutely calling out for it in all my discussions. And I think just to John's point about the sort of the cells to cities or societies, however you want to frame it. I mean, I think this speaks to a much bolder, braver sort of vision of what this is all about, which speaks to the need to speak about it through a much more positive, optimistic lens. Because, bearing the point that's been made several times about ageism, I think so often what I tend to frame things around this concept of the exposome, which really speaks to all the wider determinants and environments in which human beings thrive or not thrive. And I think this speaks also to the point that John made about there's been good work with age-friendly cities, but I think we have to be even much bolder than that, because unfortunately the age-friendly cities tend to focus on the plus 50s and making environments that work plus 50s. I think we have to we have to think of it from across the life course, which has come out again and again, see this as an intergenerational opportunity to redesign our environments. And so just going back to the National Innovation Center for Aging, they have a concept around longevity cities, which is an intergenerational approach, engaging citizens, kind of doing what Sidewalk Labs try to do in Toronto, but in a very different data model where citizens share the data for public benefit. And I think that's where the really interesting debate is on data sharing. It's like not to drive up profits of the tech firms. It's about driving up ethical research for the public benefit, the public good, while stimulating enterprise and making companies profitable. So I think that's a whole interesting space that I think merits a lot more focus and attention, is very much what we'll be doing with our innovation mission. But finally, I think, yes, speaking to this narrowing of the mindset, this is the problem. We need to completely reimagine opening up the cultural traps that we find ourselves in and just rethink what this is all about. And I think that's the real challenge for all of us in this conference, is to really set a whole new vision and not go down the silos, the disease states, how things are done. We need to think much bigger than this, and all of us together should be able to do that and hopefully bring a lot of people with us on the journey.
Thank you, Tina. We are winding down in our time for this session, but I want to recognize Adrienne and then Nahid. And I don't know if we'll have time for lightning round sort of comments on who else should be around the table as we're designing and discussing a national policy. And assuming we adopt one, what are some steps to from one that is proposed, one that's adopted and actualized. I know that people who are higher up on the ridge, countries that are higher up on the ridge than the United States in terms of thinking about national policies for healthy longevity, you've set objectives perhaps, and maybe you have lessons for us as to what has worked and what has not worked. But those are all big issues. So let me turn first to Adrienne.
Okay, I'll try to be quick then. Going back to John's point about, can we afford, when people ask, can we afford to do this, it's more of the question I think that we need to pose back to policymakers is we can't afford not to. So Singapore does not have a national aging strategy out of the goodness of its heart. It's because GDP is everything. And we need people to work longer, which is why we need to look at employment practices. We need people to be mentally acute, which is why we're looking at lifelong learning. We need to, like, that it has to happen is because Singapore has, Lee Kuan Yew long recognized that without natural resources and being this vulnerable little island that's 31 miles by 16 miles, is that its people are its only resources, which is why it can't stop investing at a certain age, but has to continue investing across that lifespan. But I think which is why it makes it easy to bring back that argument to a GDP growth argument of saying the only way we're going to continue to grow is when we want that productivity, when we recognize that we want that productivity to last as long as possible, whether that is not just working, but volunteering. AARP has done phenomenal research looking at, the economic contributions of older people beyond just, not beyond the working years. So I think as we continue to make that argument and also around that general, again, health promotion argument as well, which I think I probably have already stated this a few times. So I'll stop there. Again, there's multiple levels to address these. Oh, one other comment really quick is when we look at what other information we need, and people are raising biomarkers quite a bit. Before I moved to Singapore, I worked in low-income communities in the US doing health promotion. And if you ask any person, what is keeping you from being healthy? Are you stressed? Where do you get your food from? Do you feel safe in your community? They can answer all of these things. And these are the biggest contributors to if someone is going to be healthy or not. So I think we also have to reframe who we bring to the table. So when you're asking at who else should we be talking to, corporations, one thing that's great is aging is increasingly making it into the DEI agendas at a number of companies. It's still a tiny fraction of companies that are doing this, but it is making it into the agenda, and we need to bring them on as our champions in this as well.
Thank you, Adrienne. Naheed, please. Are you unmuted?
I'm double muted. I apologize. Two very quick points. One to what I think both Steve and Tina have talked about a couple of times, which is in my field, infection control, it's like built environment interventions, right? The idea of like the spacing and so in infection control, we talk about that in terms of like what you can change in terms of behavior and environment. A big part of what crosses between both the pandemic preparedness field and what we're talking about here is actually air quality, indoor air quality. And I say that as a selfish plug because tomorrow the White House is hosting the Indoor Quality Summit. And so I don't have access to chat on government computers, but very important partly because forget, just impact that we've seen in COVID. Influenza that costs, I think, like $87 billion in direct and indirect costs annually, right? I mean, and this is across all different interventions, age groups. And so the quality of life and the longevity issue in terms of our next sanitation revolution, air is part of what we would do to keep everybody safe. Two, I just want to raise a question that, as you guys are having this conversation about the amount of money spent on Alzheimer's versus aging versus longevity, the thing that I was thinking in the back of my head was the amount of money that's not spent on neglected tropical diseases, which made me think about this idea of when we say longevity, I think it's equally important to talk about longevity for whom. I think that, we are increasing amazing incremental lifespan for some groups. And I think a big part of the work that I do is always just focusing on how cholera research and our even understanding of like simple things about, good cholera vaccines that help save lives is so limited by funding as well. So I just want to put that out there. Thanks.
Well, just to try to wrap this up, we've had a lot of ideas. We've had a talking session, so great ideas that have come out. What happens? How do we translate these ideas into policy? And then how do we actualize the policy? Maybe some lightning round comments to finish out the session. Tom, at some point, this has to be turned into legislation or executive branch initiatives, or I don't know, does it sort of bubble up in the free market United States? Different sectors will just do things and it'll all turn out well. How do we progress from here now that we've talked about stuff?
Yeah, so I think there's a couple things. One is to be more specific. So if you talk to policymakers, you find that they are overwhelmed and that they have a lot more on their plate than there are hours in the day. So if you just go to them and say, you should be thinking more about healthy longevity, that is unlikely to be all that effective. So I think it's more effective to say, all right, if I were able to convince policymakers in the executive branch and the Congress to pay more attention to this, what is something concrete that they could actually do? So that's number one. And number two, I think advocacy is a context sport. As Steve alluded to, the experience of the aging research community is that when they have taken the time to educate members of Congress and their staff, that they are receptive to the message and they're willing to act. So I think those are my overall two pieces of advice. One is be specific, and the second is interact with policymakers in both the executive branch and the Congress and provide specific ideas that you think will move the ball forward.
Adrian, is that a new hand or an old hand? Just checking. I think Dave Fox, you had a comment.
Yeah. I just wanted to draw on one experience. That's it. How we address smoking in this country and tobacco use. And for many years, it was regarded as a lifestyle and social issue. And during my tenure at the Food and Drug Administration, I was privy to watching David Kessler stand up and announce once and for all that tobacco use in our country is a pediatric disease. And that his approach of declaring it a pediatric disease and looking at it through a drug regulatory and device regulatory context really changed the whole terms of the debate. And the rest is history. The agency sought to regulate tobacco as a drug, went up to the Supreme Court, lost by a hair, and then got express congressional authorization to do so. But that signal moment of reframing how we looked at something we lived with for such a long time with so much frustration, and tackling it and declaring it a national pediatric disease was just a standout moment. And I look for something like that here to change the balance, at least within, again, my narrow, to use Dr. Bedelia's term, my narrow aperture of the regulatory space over products and interventions. And I think we need that kind of power moment to change the balance.
It's not declaring chronic diseases to be pediatric diseases, but it's
no.
that
That reframes it.
Well, I think with the time kind of winding up, I want to thank everybody. This is a fabulous discussion. I learned a lot, and what I'm also hoping is that this conversation can continue. It's never a one and done conference, session. You talk about stuff and then you go on. And it doesn't make any difference. 3 weeks later, you're all busy with other stuff you're doing. That's a pet peeve of mine. I hope that there's something that we can do cumulatively in terms of building wisdom and then taking actions that actually get stuff done. And we do hope to continue the conference conversation through chat in a way at the Kitalys virtual campus and elsewhere. I hope that you all, as well as the audience, make connections. If you found points that were interesting, this is, again, the sign of a successful dinner salon is that we put together guests who had an interesting time and there'd be consequences, not just mere entertainment. So I want to thank you all at this stage.